Good afternoon, teacher. My name is Laila Maya. My topic is antibacterial envelope to prevent cardiac implantable device infection. Definition: infection after placement of cardiac implantable electronic device are associated with substantial morbidity and mortality.
Number 7. Antibiotic envelope for cardiac implantable device infection prevention.
Pacemakers and defibrillators are life-saving electrical marvels, but do not come without risk. Infections occur in 1 to 4% of cardiac device implantations and can lead to a 25% one-year mortality rate. Treatment costs average around $60,000. Until now, giving the right antibiotics right before the procedure was the best and only proven way to prevent infection. Despite this, infections continue to occur. The recent innovation of an implantable antibiotic envelope ensures delivery of 2 antimicrobial drugs locally in the pocket for 7 days after implantation surgery. The week-long release of the drugs minimizes the risk of infection. The absorbable envelope received FDA clearance in 2013, but healthcare professionals were awaiting results from the landmark worldwide randomized RAPID trial. The findings, published in March, show a 40% reduction in major infections, making cardiac implantable device procedures safer for patients.
Application in nursing. We conducted a randomized controlled clinical trial to assess the safety and efficacy of an absorbable antibiotic eluting envelope in reducing the incidence of infection associated with CIED.
It's nice to be part of something that really will impact somebody's life.
We've made a quality product that's going to help people extend life and cut infection down dramatically.
It's a critical division for making products that add value to lives.
A world-class facility to ensure the health of our patients.
We've designed this facility to support the long-term growth of this company.
We wouldn't be where we are today without the team. Without this specific set of people and skills, we wouldn't be as successful as we are.
They're the ones that, put the rubber to the road and really make the product happen day in and day out.
I think it's just making everything come together at the right time and having the team all on the same page.
It's a proprietary process that makes the product very special.
My work helps ensure that the manufacturing process is reproducible and reliable, that a quality product is going to the patient.
Streamline our processes, make them more efficient, cut down our run times, get our polymers into our product line faster.
We want to make sure that everybody around the world has this product when they need it.
One of the interesting parts about this product is that it was originally launched as a cardiac, and there are a lot of applications for this product.
We have the space here, capacity here, to manufacture not just Tyrix envelope, additional Tyrix products as well.
I would like to see this product be used for almost every patient and every application.
We expect it to be applicable to lots of other areas in Medtronic that can use this sort of antibacterial approach.
I'm very, very proud of the envelope manufacturing that we're bringing in-house. It helps our patients, and it really makes a large impact.
Bring new products to market, helping to save lives and to extend life.
I think it comes through fabulous communication, collaboration, and trust that we have for each other and the quality of work that we do.
Pros. 1. Reduce the rate of major infection by 40%. 2. It is a safe measure that does not increase surgery time.
To the central venous system without the presence of an external catheter. The portacath is implanted subcutaneously, usually along the anterior chest wall, although other sites may be used. It is sutured to the muscle fascia.
Catheter conformation and use.
The initial placement of the venous access device catheter tip is confirmed by radiographic exam. Catheter tip location is verified prior to use for patients with a previously placed venous access device. The patient's history and assessment should include current catheter function, a thorough assessment of catheter dysfunction, and if your medical record confirmation of the catheter tip placement is not available, a radiographic confirmation will be obtained prior to using the device.
Equipment.
In order to access a portacath, you will need the following things: a central venous catheter dressing tray, which includes sterile latex-free gloves, a mask, chlorhexidine sponge, a 4x4 gauze, an occlusive dressing, and tape. Other items you will need are a right-angle non-coring needle, topical anesthetic such as Emla or Elamax, a needleless connector, and a 10 cc sterile normal saline syringe.
Procedure.
Whenever possible, use topical anesthetic prior to access. Explain the procedure to the patient and/or their parent to promote understanding and cooperation. Clean off the bedside surface you will be working on to prevent the spread of infection. You may want to ask your patient to lie down during the access, as this makes it easier to stabilize the port. However, some patients may choose to sit up during the access. Open the central venous access dressing tray and don a mask. Perform hand hygiene, including a 30-second hand wash. Open your sterile field. Open your sterile non-coring needle set, 10 ml sterile normal saline syringe, and needleless connector onto the sterile field. Don sterile gloves. Attach the needleless connector to the needle set and prime with sterile normal saline. Close the clamp and return it to your sterile field. Be sure to check your institution's policy in regards to which antiseptic agent should be used to cleanse the skin prior to accessing the port. Cleanse the skin with ChloraPrep cleaning solution per your institution policy. Utilize a 30-second scrub in a back and forth and up and down motion, including the entire area where your dressing will adhere. Palpate the area of the implanted port with your non-dominant hand, locating the center of the port's septum. Rotate the site with each access. Do not use the same hole for each access, as it will lead to skin breakdown. With your dominant hand, firmly push the needle perpendicularly through the skin into the device until the needle meets the bottom of the device. It is important that there be a small space between the needle and the skin line. If flush with the skin, the needle length is too short and there is an increased risk of infiltration. If necessary, support the space between the needle and the skin with a folded 2x2 gauze to prevent rocking of the needle, which can cause damage to the septum and irritate the skin. Gently flush with 3 to 10 ml of normal saline or aspirate for blood return to verify proper placement. Apply an occlusive dressing. If necessary, cover the wings of the extension set with a folded 2x2 gauze to prevent inadvertent removal of the needle when taking off the occlusive dressing. Of note, gauze placement is often used for short-term portacath access to stabilize the needle. If needed in place for a longer period of time for continued needle stabilization, please review your institution's infection control policy regarding how often to change the gauze, as it can be a medium for bacterial growth. Apply tape around the tubing where it exits the dressing to ensure occlusiveness. Unclamp the extension tubing and gently flush with 3 to 10 mL of normal saline and connect to your administration set. Date and initial your dressing. If you are not connecting to an IV infusion, scrub the cap with alcohol for a minimum of 15 seconds and allow to completely dry. Flush with 5 mL of heparin, 10 units per ml, and disconnect the syringe and clamp the set. Secure the portacath to the patient at a second site by taping to the skin or pinning to the clothing to prevent tension on the tubing and needle, which can cause an inadvertent dislodgement. Document the needle and dressing change in your patient's chart.
Post-procedure catheter care.
Some other important information about portacaths. Change the dressing when the non-coring needle is changed or if the dressing becomes loose or soiled. The dressing should remain occlusive at all times. Use only non-coring needle sets, right angle. These are available in various lengths depending on the size of the patient. Change the non-coring needle a minimum of every 7 days. The needle may need to be changed if you experience difficulty flushing or if you are unable to obtain blood return. This concludes our video on accessing a port.
Cons. 1. More comorbidities in patient. 2. Access at a point. Issues applied in Ecuador. Among the problems applied in Ecuador is bad hand hygiene.
Impulses that synchronize the heartbeat. The animation shows the top part of the device to which the wires are ultimately connected after being inserted into the heart. The anatomical picture here shows the major blood vessels going into the heart. The blue vessels are the veins in which the first wire is being placed into the right ventricle, the lower chamber of the heart. The best location is chosen and the wire is secured in that location. After testing is done, a second wire is introduced into the right atrium of the heart, which is the top chamber seen in the animation. In order to target the best part of the heart on the left side for the resynchronization lead, a catheter is inserted in the coronary sinus vein. A balloon is inflated and dye is injected. This dye, shown on this X-ray image simulation, shows the picture of all the blood vessels on the left side of the heart that can be potentially used to insert the resynchronization lead. After the proper location is chosen, a left ventricular lead is placed through that catheter, which is a small tube allowing position of the lead, and inserted into the target vein. The image here shows the lead being introduced into the distal or the furthest part of the vein that provides the best therapy. After this lead is positioned and secured, all the wires are attached to the generator, which provide resynchronization and improvement in heart failure symptoms.
Conclusion. The use of an antibacterial resulted in a significantly lower incidence of CIED infection.
Sometimes it makes sense to use a vascular access device, a small port and catheter that allows medication to be administered directly into a large central vein. Using local anesthetic and guided by ultrasound and X-ray, a radiologist will insert the thin, flexible tube into a large blood vessel leading to your heart. The port itself is generally placed on your upper chest, just beneath your skin. The procedure is easily performed with minimal risk and pain. When the procedure is over, medication or intravenous fluids can be administered without the discomfort of multiple needle pokes. The device is a long-term solution for ongoing treatments. You'll need to keep the incision clean and dry and avoid strenuous activity until it heals. To learn more about the day-to-day care of your implanted vascular access device, consult your nurse or a member of our care team.